This patient has been diagnosed with a macular hole in the left eye. To repair a macular hole, a 3-port pars plana vitrectomy is set up. The 23 gauge cannulas are used in this case in order to allow larger instrumentation, which makes the surgical repair easier as the instruments are sturdier. The inferior infusion cannula is in the eye, and the superior ports are used for the light source and the vitrector. We're using a wide-angle viewing system. Sometimes for macular holes we like to have a more magnified view of the macula, but the wide-angle system allows us to see the entire retina during surgery, and we can also use a high magnification condensing lens for the macular work. Macular hole surgery basically involves eliminating all tractional forces that created the macular hole, which then allows the macula to come back together and for the hole to close. A macular hole is not a true hole in that there's no missing piece of retina. Essentially, the retina is stretched apart, and by taking away the tractional forces, the retina can come back together and the macular hole can be repaired. The first stage in macular hole surgery, which is being carried out right now, is the core vitrectomy. And right now the vitrector is being used not only to remove the central vitreous, but also to elevate the hyaloid. You can see the reflections and off the transilluminated posterior hyaloid, and the hyaloid is currently being lifted with active suction by the vitrector. The vitreous exerts traction on the macula, as does the posterior hyaloid. So it is important to remove the vitreous as well as the hyaloid in order to aid in releasing all traction. Sometimes it's a little bit tricky to elevate the hyaloid. Most macular hole patients have a fairly taut hyaloid, which in part is why the macular hole develops. So oftentimes quite a bit of suction is used around the optic nerve to create the separation of the hyaloid. And once the hyaloid is separated, you can typically see the edge of the hyaloid and often see the Weiss's ring overlying the posterior pole. Once in a while, with a good view, you can also see the operculum or pseudo-operculum, which had previously been over the macular hole in the posterior vitreous cavity. The initial phase of the surgery just takes a few minutes. During that phase, the hyaloid and the central vitreous are removed. After that, the peripheral vitreous is removed, and the vitreous is trimmed as far as possible to the vitreous base. After that has been performed, it's important to inspect the peripheral retina to make sure there are no tears. Once you've confirmed that there are no tears, indocyanine green, which is a green dye, is injected into the vitreous cavity and is allowed to stay there for approximately 45 seconds. The purpose of ICG, or indocyanine green, is to stain the surface of the retina so that the internal limiting membrane can be visualized more easily. Without ICG staining, the internal limiting membrane is essentially invisible, which makes peeling it difficult. With the ICG, the ILM becomes prominent, and it's fairly easy to remove with the appropriate equipment. So the indocyanine green has been injected into the vitreous cavity. We've left it there for about a minute or so, and now a soft tip cannula is in the vitreous cavity, which is sucking on the vitreous, or what's the liquid that's currently in the vitreous cavity, and is removing the ICG. A soft tip cannula now with a siliconized tip with little diamond chips, which is called a tannon diamond dusted forceps, is now being used to elevate the internal limiting membrane. The internal limiting membrane is peeled off the macula much like a capsulorhexis is performed. An edge is created with the cannula, and then a forceps is inserted into the eye, and the forceps is then used to grasp the edge of the partially peeled ILM, which is then peeled completely around the macula. You can see the large macular hole in the center of the photograph, at the center of the video, and the internal limiting membrane forceps are now gently elevating the ILM off the macula, which will then be removed from the eye. You'll see as the ILM is being peeled across the macular hole that there's quite a bit of tension on the edges of the macular hole. So in addition to the vitreous and the posterior hyaloid exerting pressure and tension on the macular hole, the ILM also exerts traction on the macular hole. Before ILM peeling was incorporated into standard macular hole surgery, typical success rates for macular hole surgery were approximately 80 to 85%. With ILM peeling, As you can see now, the ILM is off the macula. The success rates approach 90 to 95%. This hole is fairly large, and the hole likely has been there a little bit longer than the typical macular hole, so the success rate is not quite as high as a fresh macular hole, but nevertheless the success rate is quite high and is likely approximately 90 to 95%. It's important when peeling the internal limiting membrane to be careful not to touch the retina. If the forceps touch the retina, often surface vessels on the retina will bleed, and you can have little spots of blood on the macula. Now that typically goes away, but certainly it's better to limit bleeding on the surface of the macula. Once in a while, if not careful, the forceps can actually create a little bit of damage to the surface of the retina, and sometimes even some RPE markings as a result. After the ILM has been peeled, air is inserted into the vitreous cavity, and the air will replace the fluid. So as air is going into the vitreous, a soft tip cannula is inserted into the vitreous cavity, and the fluid is sucked out over the optic nerve. An entire air fluid exchange is performed so that all fluid is removed from the vitreous cavity. Typically we'll then let the eye sit for about 5 minutes, because sometimes some fluid will reaccumulate posteriorly, and a second air fluid exchange is performed to make sure that the macula is completely dry. Once the air is in the eye, gas is injected. In this case, we typically will use a gas called SF6, which is a shorter acting gas. If there's a chronic macular hole, sometimes we'll use C3F8 gas, which is longer acting. The SF6 typically stays in the eye for approximately 2 weeks, and the C3F8 for approximately 6 weeks. With macular hole surgery and successful ILM peeling, often we can just have the patient face down for 2 to 3 days with successful macular hole closure. We usually ask them to do the full 3 days just to make sure, but some surgeons actually are doing less than that with good success rates as well. At the end of the surgery, the trocars in the infusion are removed from the eye. The incisions are cauterized for hemostasis and to make sure that the incisions are watertight, and the surgery is essentially complete. The patient will go home with a patch, and we'll begin face-down positioning.